Hi, everyone. My name is Dr. Tricia Scaglione, and I am an assistant professor with the University of Miami Health System and the director of their Tinnitus and Sound Sensitivities program. I'm here to talk to you today about some common cases that I see in my clinic. And so what we're going to talk about is a tinnitus, hyperacusis, and misophonia patient walk into a clinic. I have no disclosures. The first patient I want to introduce to you is a 55-year-old woman named Phoebe. Phoebe came to the clinic to see our ENT to discuss some sensitivities she was experiencing to loud noises. She had also mentioned that she was really distracted by sounds in her environment, her work environment, and her sleep environment, which were impacting her ability to execute her job responsibilities and to sleep at night. She mentioned she had some bilateral noises in her ears, some bilateral tinnitus in her ears. However, those noises only occurred sometimes and they weren't really bothersome to her. Medical history was significant for breast cancer. She was treated with chemotherapy in the early 2000s. And she did mention that she has pre-existing sleep issues, that she's just a light sleeper and usually uses over-the-counter earplugs to help her at nighttime. The ENT referred the patient to have an audiogram performed with an audiologist. And as you can see here on the screen, the results demonstrated normal hearing sensitivity bilaterally. I'll also mention that TIMPs were completely normal. The reflexes were deferred due to report of subjective sound tolerance issues. The patient also underwent DPOAE testing, which demonstrated robust responses bilaterally. And this test by the audiologist on this day did not include any loudness discomfort testing, as that was not part of the routine test battery for that clinic at the time. The patient then followed up with the ENT, who diagnosed the patient with hyperacusis. The ENT referred the patient to pursue further services with our Tinnitus and Sound Sensitivities clinic. And at the request of the patient, the ENT also recommended custom sound plugs. So the individual went back to see the audiologist they saw earlier that day to have ear mold impressions made for custom-made sleep plugs. So I first saw this patient when they presented to our Tinnitus and Sound Sensitivities clinic. The first step that we have patients take part in is a virtual education session for tinnitus. However, this patient was misscheduled as they weren't really bothered by their tinnitus. It was more the sound sensitivities. However, it ended up being a blessing that they were scheduled that day because the other individuals scheduled for the group session didn't present. Therefore, the individual and I, this patient Phoebe and I, were able to have a private virtual session together. And instead of tinnitus, we talked about hyperacusis. Switching gears, I asked her about her history and her symptoms, and she relayed that soft and normal volume sounds, average volume sounds, weren't really bothersome to her. They didn't cause pain, they didn't cause any issues, but she was really bothered by very, very loud sounds. She also found that she was very distracted by sounds in the environment. Her elderly parents were living with her and listening to the television very loud during the day, which was very bothersome to the patient. Because of the COVID-19 pandemic, this patient has been working from home, working remotely, and having her parents in the household were very distracting from her. And that was what was actually bothering her from being able to function and carry out her job responsibilities, because she was very distracted. She did mention that this distraction was something that she has faced in life, that if she goes into a restaurant and there's background speakers, or even in crowds where there's 2, 3, 4 people, she has a really hard time focusing on having the conversation with an individual or reading or carrying out a task. If there's any other kinds of distraction, it becomes overwhelming to her. Loud, very loud sounds like train, the squeal of train brakes is very bothersome and uncomfortable to the patient. But again, it has to be very loud for it to be bothersome for her. She mentioned that when she goes to work, when she's physically in the office, she takes the train, and that's how she knows that sound is provoking for her. And at night, she has difficulty sleeping again because she hears noise in her apartment complex, which just keeps her awake, but again, does not cause pain and is not considered to be quote unquote too loud for her. So let's take a moment and let's discuss hyperacusis. I picked this case on purpose because I feel like there's a lot of misconceptions when patients present to a clinic, whether it's an audiologist, a nurse practitioner, an ENT, and they say they have sensitivity to sounds. Quite often I see them labeled with hyperacusis. But hyperacusis is a reduced tolerance to sound. Usually that reduced tolerance, depending on what school of thought you follow, is either sounds under 90 decibel, anything under 90 decibels is sensitive to the patient, or a more conservative school of thought is that anything between 70 and 90 decibels is considered a decreased sound tolerance, while under 70 decibels is considered an actual hyperacusis, a very, very extreme sound sensitivity. Regardless, let's just say anything under 90 is a reduced tolerance to this sound. And this can also cause pain to the individual. But usually normal, low volume or average volume sounds are not an issue to patients, and they usually don't report pain with those sounds. Also, I want to clarify that recruitment and hyperacusis are different, that recruitment occurs with certain sounds, usually in the range of a hearing loss, where the hearing loss is present. But with hyperacusis, generally it's all sounds in that environment are too loud for the individual. Hyperacusis is not that common. It occurs in about 1 in 50,000 individuals due to, it can be because of loud noise exposure, Bell's palsy, Lyme's disease, or various other conditions that may result in the sound sensitivity. While this is not an actual, these aren't actual scores here of my patient, Phoebe. A typical hyperacusis patient will show loudness discomfort levels, uncomfortable loudness levels that are in this reduced range you can see on the audiogram, not only for pure tones, but also with speech stimulus. When these patients come into clinic, I would always recommend, it is recommended that the patients undergo an audiometric evaluation and also have the UCLs or LDLs and MCLs evaluated. Be very careful when testing acoustic reflexes, as these patients can, these sounds can be very painful to patients, especially if they truly are a hyperacusic patient. If you must conduct acoustic reflexes, it's recommended that you first conduct the UCL, LDL testing first to figure out their threshold of pain, and then go ahead and conduct the reflexes if you absolutely must, keeping the presentation level lower than their LDLs. There are also some subjective questionnaires that you can also use to help screen your patients. One common questionnaire is the modified CALFA questionnaire that you may be interested in learning more about. So let's think about Phoebe. Based on her symptoms, does she have hyperacusis? Again, she has normal tolerance to average and low volume sounds. She's more distracted by the sounds, and she's not having pain either. So most likely not. This patient's probably not having hyperacusis. So now we want to think about, what does this patient have? Phoebe probably has some form of a central auditory processing disorder where her hearing is normal, so the periphery is fine, but once the sound gets to the brain, to the auditory cortex, the processing centers then aren't processing the way they should be, therefore resulting in her having challenges of being able to concentrate when she's in the presence of sounds or multiple sounds or complex sounds. And so I recommended that she consider a CAPD evaluation. We also talked about work and lifestyle modifications. We discussed how she could help her elderly parents, maybe even getting some assistive devices or TV ears for the television, which would allow them to hear the TV, but allow her to be less distracted. And she did talk about that she's going to be returning to the office in a couple of weeks. So she wanted to first wait to do the CAPD evaluation to see her transition back to the workplace, to see how she would do, though she suspects she will go for the evaluation because the issues have been a challenge for her for many, many years. It just was really brought to light during COVID when she tried to work at home. I addressed the fact that she was using earplugs and really drove home the point of, if you're going to use earplugs, how to use them safely and to avoid overuse, because overuse of earplugs can certainly result in an increased hypersensitivity to sound. So we talked about that at length, and she confirmed she understood, understood and will refrain from overuse. And the next time she's in clinic, most likely I'll go ahead and assess those UCLs on her. But I assess the most, I feel that they will most likely be normal. So let's say this patient did have hyperacusis. If Phoebe did have hyperacusis, what would we do to manage her? Ear level sound generators using a very low sound stimulus level that's gradually increased in time can help to improve hyperacusis or decrease sound tolerance. It can take some time, 6 to 8, sometimes 12 months to build this tolerance up, but it is absolutely possible to do so. Cognitive behavioral therapy with a mental health therapist can also be very helpful. And if there is an underlying condition, it's very important that that is treated by a medical physician. And as I mentioned with the earplugs, if a patient must use earplugs, it should only be situationally where the sound is truly uncomfortable to the patient and they're trying to engage in that activity. And I recommend using, it is recommended, I should say, to use filtered plugs, musician plugs, with a low level attenuator if they must use plugs, trying not to over plug that patient if possible. And again, really, if you can get away with not having your patients wear plugs, that's better. But we also don't want them to be a recluse and confined to their house. So we want to, find the balance there. The next patient we're going to talk about is Hannah. Hannah is a 14-year-old female that came to the clinic just recently. I saw her just a couple of weeks ago with her family members. And Hannah reported that since the age of 3-4 years old, she has been experiencing uncontrollable emotional responses to certain sounds. Certain sounds will trigger her to have this panic attack or violent reaction, these outbursts. She'll cry. And it's very stressful for her, and it's very, very stressful for her family. Her trigger sounds specifically are chewing, swallowing, snoring, and loud breathing. And the trigger sounds are primarily coming from family members. Those around her, her classmates, her friends can do the same exact trigger, and it won't actually bother her at all. Throughout case history, I also learned that there is a presence of obsessive compulsive disorder tendency in the family, though no formal diagnosis, though the patient herself denied any OCD tendencies. And when I asked the patient, how are you currently coping with your symptoms? She indicated that she would try to avoid being around her family members when they're eating. She also had visual triggers, I should mention that. So besides the auditory triggers, she also had visual triggers, specifically with eating. So she also tried to be out of line of sight when individuals were eating, or tried to keep her head down. And she tried to wear her earbuds and listen to music, her Apple iPods, as much as possible to help have some kind of background distraction. Otherwise, she denied all other otologic issues, any other health issues, no dizziness, no previous noise exposure or chemotherapies. She didn't have an audio on file, so I did a full comprehensive eval with her. Emittance, tims and reflexes, completely normal. Her audiogram demonstrated normal sound sensitivity bilaterally. I conducted extended high frequencies. Extended high frequencies were also well within normal limits for both ears, and tested her loudness discomfort levels, which, as we know from the other presentation, they are over 90, so she has normal sound tolerance in both ears. So no concern for hyperacusis here, and her history doesn't suggest hyperacusis. We also assessed DPOAEs in both ears, 1,000 to 10,000 hertz, and everything was normal, nice, robust responses there. So what is this patient suffering from? Well, Hannah is experiencing what we call misophonia. And misophonia means a hatred of sound. And it's actually a neurophysiological and a behavioral condition where an immediate physical response occurs due to a trigger, which can be auditory or visual in the majority of cases. And it's thought to be an overactivation of the nervous system, specifically the limbic and the autonomic nervous systems. And these responses from patients can range from the patient being upset, they can become verbally or physically abusive, they can have the misconception that the individual causing the trigger noise, that they're rude and that they're inconsiderate in doing that on purpose. It can cause anxiety. It can cause a sensation that the patient experiencing the sensation that they just suddenly want to flee. So it can be very consuming to the patient. And common sounds happen to be eating sounds, mouth sounds, lip smacking, sniffing, chewing. It can sometimes be tapping or pen clicking, pretty normal sounds. And these sounds presented are not a loud volume sound. They're pretty soft. Misophonia can happen with any sound, but most of these sounds are pretty average or low volume sounds. And again, they don't cause pain to the patient, but they do cause this sudden emotional or physical reaction. And the triggers usually come from family members. Usually it's somebody that lives in the household with the patient. Onset of symptoms is usually prepubescent, usually around 10, 11, 12. The symptoms tend to come on. This patient was pretty young when hers came on, but usually we see it in young adults. And usually more so in females than males. There are a number of misophonia questionnaires that you may consider using with your patients in the clinic as a screener. For this particular case, I used the AMISO-S, the Amsterdam Misophonia Scale. And as you can see here, it is just a very quick, easy scale to help me assess how the patient is experiencing their misophonia, what are some triggers, how are their responses, how does it make, does it distress the patient? And then at the bottom of the page, it says, what's the worst thing that could happen if you're not able to avoid these misophonia sounds? And the patient here wrote, she lashes out on them, meaning the individual causing the noise. And I have a panic attack and I leave, most likely crying. So, this is terrible. I mean, think about these noises: breathing, lip smacking, chewing. How many times a day do we ourselves make those noises? And this individual has to live with this every single day. So extensive counseling was provided to the patient and her family. And recommendations included sound enrichment in the environment, wherever the patient is, where those trigger sounds are. And it can be in the environment or it can be ear level or both. For ear level, we talked about her ear pods, we talked about sound counseling headphones. We even talked about bone conduction headphones like aftershocks. We talked about ear level sound generators that she could use and pair to her cell phone to stream ambient music or apps in. She was actually really excited about the sound generators. She really liked those because she thought they were more discreet than the AirPods. She feels with the AirPods always on, she feels very rude, especially if it was around a social situation. We talked about strategies to avoid or reduce visual triggers, like keeping the visual triggers out of line of sight or using sunglasses or similar techniques. We reviewed stress management techniques and relaxation techniques. We went over guided breathing, guided imagery. We talked about aromatherapy. I presented to her a number of different apps that she could very easily download on her phone and be able to access whenever she needs. And then we talked about mental health counseling. This is a huge, huge important factor for patients experiencing misophonia. Dialectical behavioral therapy, or DBT, is a modified version of CBT, which many of you may be familiar with. CBT is a very, very popular type of therapy that's used for many different health conditions. And DBT has been shown to be effective in with some misophonia patients. So DBT tends to be referred for a little bit more than CBT in this particular patient population. Besides DBT, family therapy was also recommended because Misophonia not only affects the individual experiencing the symptoms, but also those who are causing the trigger sounds. And again, it's quite often the family. So family therapy can often be a very, very important part of the management plan. And the pediatrician also, we want to make sure that the patient is following up the pediatrician to make sure there's no underlying health conditions, and keeping the pediatrician in the loop with her misophonia evaluation. Now, I just saw this patient, as I mentioned, a couple of weeks ago, so she's going to be following up with me in about a week. Right now, the session's being recorded pre-session, so I'm hoping that I'll have an update that I can write in the chat for you in the actual session in November. But the patient did message me that she has actually been established with a DBT provider, so that's great that she's moving right ahead with that. And I believe the family is going to pursue ear level sound generators when they come in this week, so that'll be great. I also mentioned a 504 accommodation letter can be provided in case the student needs that to be able to use any of her devices in the classroom. So here we can see the difference between the hyperacusis patient, where they were really bothered. If it was hyperacusis, the hyperacusis would have been bothered by the volume of the sound. Here, it's not the volume, it's the actual, the context of the sound itself. The third patient we're going to talk about, patient number 3, we're going to call him Denzel. So Denzel is a 62-year-old male that presented to clinic. He has a history of left ear noises for the past few years, as well as hearing loss. He feels like his hearing loss is worse in his left ear than his right ear. The noises he hears in his ear has recently worsened in volume and awareness levels for him. And he's also now hearing those sounds in the right ear. Before it was just initially in the left, now it's in both ears. He's also saying that he needs to ask family members often to repeat what is being said. He does have a history of exposure to noise, as he was in video production for weddings and other kinds of social events. Otherwise, he has no other otologic concerns. The hearing test that was performed demonstrated an asymmetrical hearing loss for both pure tones and word recognition scores. And though TIMPs were normal and acoustic reflexes were not performed by the audiologist, and the ENT had ordered an MRI for this patient, which revealed that all findings were unremarkable, no IAC lesions. So the patient was cleared to pursue hearing aids and was referred to tinnitus clinic. So let's talk about what is tinnitus. Tinnitus is the presence of sounds in somebody's head or ears that's not actually present in the environment. It's very common. It affects about 1 in 50,000 individuals. 1 in 50 million, I wrote 50,000 here, 1 in 50 million individuals in the United States alone. So it's very, very common. And common causes, so this is not extensive, but common causes are thought to be related to hearing loss, aging, head trauma, noise exposure. It could be a viral infection, a bacterial infection, medications. There's just so many things that can contribute. Even dental or cervical issues can contribute. Though in your clinic, you're going to see probably far more tinnitus patients come into your clinic rather than maybe hyperacusis or misophonia patients. So we did a full tinnitus evaluation on this patient. You can see here from these results, he would be a good sound therapy candidate. Ultimately, what this screen is showing you is that the patient pitch matched to a very high frequency sound, and it could be very easily masked to a 10 dB SL stimulus. So he seems like he would respond well to a masking or sound therapy. And his LDL testing showed a little bit of reduced sound tolerance just outside of that normal range. So we'll keep that in mind and maybe fit the hearing aids a little bit more conservatively at the beginning, just to make sure that he would be not having any sound tolerance issues there. Also, residual inhibition was neutral. It didn't show any reactive tinnitus. We performed different questionnaires, the TFI, TRQ questionnaires, which are the top 2 shown on the screen here. And the scores they did not correlate with each other. Usually we like to see a better relationship between the 2. And so I discussed this with the patient, and ultimately he felt like he mistakenly underscored the TRQ. And so we went off of the TFI score, and pretty much every domain was highly scored for him in terms of how the tinnitus is negatively impacting his quality of life. And then we always do a mental health screener, which he showed he was borderline for the presence of anxiety. We did discuss this, and I talked about the importance of following up with a mental health specialist. For management, we did discuss combination hearing aids, so a hearing aid and a sound generator for him, relaxation techniques because he did have some anxiety and stress. And then he mentioned he sometimes has some difficulty sleeping at night because of the tinnitus. So we did talk about perhaps using a sound pillow with the presence of ambient sounds. And so now hopefully you see the difference with this patient. This patient didn't have sound tolerance issues or trigger sounds, but they had noises in the ears. So when these patients present to you in clinic and you're trying to differentiate what's the difference between, what condition does this patient have, some common questions you can ask yourself are they hearing noises in their head, or are they saying they're sensitive to sounds in the environment? If they are having sounds that are bothering, they're sensitive to sounds, what kind of sounds bother them? Is it a train? Is it a vacuum? Or is it a spoon against a porcelain bowl? Those are two very different categories. And what is the volume of those sounds? What is the context? Is it a sniff, or is it a chewing noise? And how do they react to the sound? Is it too loud and they cover their ears, and that's more of a hyperacusis? Or does it cause a visceral reaction, emotional and impulsive reaction from that patient? And are there specific individuals who trigger these sounds for the patient? So these are just a couple of very common questions you can ask yourself to better identify what the patient may be experiencing. So then you can go ahead and identify the management plan and if further evaluations or referrals to other specialists are needed. And with that, I thank you. I appreciate your attendance at this presentation, and please feel free to contact me at the email shown on the screen should you have any further questions. Have a great day.
So I'm going to be talking about the auditory system, cochlea to cortex today. My name is Dr. Heidi Hill. I'm an audiologist, owner of Hearing Health Clinic, a private practice in the Minneapolis, Minnesota area. I'm also the creator of Cognition, an online training program for audiologists who want to learn how to test and treat from ear to brain. My disclosures are I am the owner of Cognition Audiology Training Program, and I've been a paid consultant for Cognition. I want to start off just by talking about the value of hearing, which I think I'm preaching to the choir here, because I hope I am, in that hearing is extremely important. But there is a significant lack of value to hearing in the public eye, and unfortunately, somewhat within the healthcare system as well. And this is problematic because hearing impairment is an important issue because it's associated with numerous health issues, such as accelerated cognitive decline, depression, increased risk of dementia, balance problems, increased risk of falling, hospitalizations, more hospitalizations, longer ones, mortality. And then there's also the social implications, such as reduced communication function, which really impacts relationships, family members. There's social isolation, there's loss of autonomy, there's impaired driving ability and financial decline. And that financial decline is with our seniors and also with our younger patients who are working and not making the equivalent of their peers. So we know, well, hopefully we know hearing is really important, and there should be a high value placed on treating hearing loss. Yet we're only helping less than 30% of adults in America move forward and treat their hearing loss. And I think a lot of people will say, well, that's because of cost. But actually, studies have looked at this, and it's not just cost, and cost is not the biggest barrier. If it was, when we look at Europe, which mostly has subsidized hearing healthcare, their help rate isn't much better than ours. And when we even look at the VA, it's where the vets don't pay for the hearing aids. It's really the same. So, you know, by taking away the cost barrier, we're going to lower or we're going to increase that help rate by no more than 15%, 10-15% at best. And I'm sorry, but 45% isn't very good either when we're talking about the issues that we're talking about. And I really think a lot of the problem about devaluing treating hearing impairment is because of our approach in hearing healthcare. And that's humbling to say as an audiologist. But our traditional approach to hearing healthcare is really only looking at the surface of our patient. We're really only looking at the periphery. We are doing pure tones, and we are doing monosyllabic words in quiet. We might be doing emittance and OAEs as well, but still just the periphery, and the relationship between real life auditory processing and pure tone sensitivity is weak. So we can't just be looking at that. And also elderly adults, not even elderly adults, just we've all seen patients with similar hearing tests and varying abilities in their speech discrimination and noise. And this explains it. Well, we can't explain it just by looking at the audiogram. That's not giving us enough information. This is really a diagnostic site of lesion view of looking at hearing loss. It views hearing loss as a problem, mechanical in nature with specific cause-effect relationship. And we're looking at a bottom-up processing view only, an afferent nervous system view. We categorize hearing impairments into conductive, sensory, neural, retrocochlear, and central, which really has no meaning to the patient. And we're really setting up the patient to believe that technology, hearing aids, and cochlear implants are going to solve their problem. This is a chronic condition, and they're not going to solve the problem. They're going to treat the problem. They are treatment. So we really need to have a more real world approach where we're looking at the entire auditory system, which includes the central auditory system. Auditory processing from the cochlea to cortex really looks at both afferent and efferent processing, looks at hearing, listening, comprehension, and communication, and its focus on functional abilities in everyday life. Patients don't leave our clinic and hear beeps and monosyllabic words. And so they really don't understand the audiogram, not because it's highly sophisticated. It just doesn't really have a whole lot of real world application unless we're connecting it to some of these other things that we're going to talk about. This approach requires ongoing care over time, which audiologists all know. We're all looking at this over-the-counter thing going, yeah, that is not going to work for many of our patients. And it depends on the patient. So if the patient's primary problem or only problem is peripheral, and that peripheral problem isn't significant, perhaps over-the-counter, a big box, that's where those things come into play. But to just straight out tell all patients, go to Costco or go anywhere really and just get hearing aids. Those patients are not going to be successful. And we're going to see that not only aren't we helping everybody, but those who we are helping who have purchased hearing aids or gotten hearing aids aren't wearing them. And so these are problems. And I believe a big part of the problem is because we didn't look at the entire system. This approach also focuses on guiding the patient through the process of behavior and attitude change, which is really what a lot of our patients need. And when we just tell them, we pick up sound with our ears, but we hear with our brain, that is not guiding the patient through any attitude change. Sounds like an excuse, actually, for why the hearing aids aren't doing what they want. And this approach really views technology as just needed to ease listening effort and eliminate social barriers and improve participation in daily activities. So when we're talking about the central auditory system, we're really talking about auditory perception and understanding, whereas that peripheral system, the outer ear, middle ear, inner ear, that cochlea, really, we're just looking at detection. So that is pretty isolated because we actually need to perceive and understand what's being said in order for us to be able to participate, engage, and connect in real life. And so that's where the central system comes in. That's the brainstem, the midbrain, and the auditory cortex. So I learned in school, and probably most of you learned, that the auditory system is an afferent bottom-up processing system. Sounds are initially coded, neural signals pass up through the auditory nervous system. Then there's advanced processing, which preserves, refines, analyzes, modifies, and organizes the auditory information. And this is really important for sound localization, spatial awareness, auditory scene analysis, auditory discrimination, and temporal aspects, all things that happen in the real world. And none of those things are in an audiogram, in traditional audiology. We don't know any of that. And so, again, important to know some of those things or all of those things, and it's important to know how patients' cognitive abilities, because sound's meaningless without the brain. And sound has to be processed through an ear-brain system that is compromised by the central effects of biological aging. So it's also compromised typically from peripheral hearing loss. And if you, and hopefully you did see Dr. Sharma and her talk, which was amazing, that's really what she showed. So this, I'm not going to spend a lot of time going through these different points along the brainstem and the midbrain, but the sound, as most of you know, goes from the cochlea to the cochlear nuclei, where the sounds are decoded for frequency and intensity. Sound is processed both ipsi and contra. And then you've got the superior olivary complex, where sound is binaurally integrated from both ears, which is important for localization, of course. Here is detecting and encoding short silent sound periods, which is really and fast temporal fluctuations in sound intensity. That's really important for ongoing speech and to be able to separate out sounds. Lateral limb meniscus, which inhibits activity coming up, so it can focus more on the salient stimuli. Looking at binaural information reduces the spectral splatter at sound onset and suppresses sound source information during reverberation. And these are really important things. We've got these, you may be seeing a patient and things are loud, but they're not clear. It's a great indication something's going on in the central system. The inferior colliculus facilitates sound localization, is important for sustained attention. And damage in this area has been linked to tinnitus and hyperacusis. And then we're going on up into the medial geniculate nuclei. Again, where attention to salient stimuli happens, moderates sustained attention. And then we go up into the auditory cortex, which is the neural core of hearing, language, and music. So that's the afferent system, but research has shown now that top-down or efferent processing is just as important as afferent processing, if not more. And in particular for our patients with hearing impairment, it's more important because it's needed to compensate for poorly resolved bottom-up sensory cues, AKA hearing loss, hearing and noise. So we all use our efferent processing for listening and comprehension and hearing, when we're in noisy places or reverberant places or multiple people are talking. This system emphasizes certain aspects of the incoming signal using cognitive factors such as attention, working memory, long-term memory, executive function, and processing speed. It's more closely connected to function in everyday life. And there's an overlap within the auditory system where efferent feedback accompanies afferent encoding. So you have encoding and feedback happening. You have this system working together. So cognition is obviously important because that's a core to efferent processing. It's an essential component for auditory function, for listening and communication. And limited cognitive skills reduce cognitive resources available for understanding speech, especially in noise and reverberation. It increases the effects of the hearing loss and speech understanding. And in particular, the areas that are really important for cognitive functioning are memory, which is processing and storage of information. Patients with poor memory are going to have problems parsing out complex sentences or recognizing speech in poor environments and degraded conditions. Memory is responsible for successful use of attention. So when I see patients who have poor memory abilities, they will tend to, when I test them in noise, they don't really try. They don't, it's too hard. They don't have the cognitive abilities to do it. And they won't pay attention for very long. An important thing to consider as a healthcare provider, giving people information. Executive function, absolutely as important. These are the two biggies. And executive function is really important for us to focus on a specific stimuli while ignoring irrelevant distractions. And that's huge for hearing, especially when there's environmental sounds and things like that. So you've got a patient, they cannot stand the noises, the car noise, everything's making a noise. These hearing aids aren't working. They don't do anything. They just amplify noise. Well, what's that patient's executive function? Really helpful to know that. So we have a better understanding of what they're capable of doing and how we can help them. Executive functions widely employed in maintaining acceptable levels of comprehension of spoken language. And what happens when somebody's got a hearing loss is executive function has to kick in to compensate. And that results in other cognitive domains not being properly supported because executive function is really kind of the executive of all the cognitive functions. So when it's busy on processing sound, other cognitive domains aren't being properly supported. Processing speed will hinder speech recognition, recognition, especially when it's just too darn fast. It impacts what can be stored in long-term memory. It's a cognitive ability most strongly correlated with impairments of everyday function. I'm trying to look at my timer, so excuse me while I try to figure out how long I've been talking. There we go. All right, aging. So we have this whole auditory system, cochlea to cortex, and then age affects the entire auditory nervous system. Really quick, and this is not an exclusive list. There's so many things that happen with aging, but the things we know, some of the things we know: decreased spiral ganglion cells, degeneration of interhemispheric transfer, degeneration of neural processing in the brainstem and cortex, neural distortion, timing issues with binaural hearing, reduced strength of sound, even when the audiogram is normal. 26 million adult Americans have hearing impairment, hearing difficulty, and a normal audiogram. Age-related changes in temporal processing have emerged as a prominent characteristic that may be contributing to reduced age-related cognitive performance on measures of memory and comprehension. Even if the patient is not an obvious candidate for hearing aids because of good thresholds, they show problems in temporal processing, which results in difficulty hearing and noise, poor memory and comprehension skills. These patients come to us for help, and we're like, your hearing's great. Well, your peripheral system's good. So that's indicating there must be something going on with the central system. And we can't just tell the patients that. We need to actually test that, and we need to help those patients. And how do you do that? Well, you have them come back so you can do more testing, or you refer out to people who are doing it. But to just tell them, yeah, you're good, let's just monitor this, is really failing a lot of our patients. Symptoms of central change. I know that most of you guys are working in an ENT clinic. You don't have time to do more testing. You might be thinking, oh my gosh, yeah, this is really great, but yeah, no. When you're in clinic, you can't, right? You're really looking at the peripheral system because that's what you're doing in the clinicals, in your clinic with your ENTs. But when they're coming back in for an HAE, say, you've identified a problem, or their audiogram was normal, but it's not matching up what they're hearing. Who do you bring back to do more testing and looking at that central system? Patients who are hearing but not understanding speech, especially in noise, difficulty paying attention and remembering information that's spoken, memory difficulties when information is presented simultaneously or with multiple modalities, difficulty carrying out multi-step directions, poor listening skills with need for slower rate of speech, need for longer processing time, difficulty following lengthy conversations, understanding conversation on the phone, reverberant environments, difficulty localizing. Their hearing difficulties are disproportionate to the degree of hearing loss. You need to be doing some kind of hearing handicap measure, subjective measure, or disability measurement to know that. Lack of music appreciation, difficulty following complex directions. Put a few of these questions on your intake form so that you have just a little bit more information to know, okay, who needs what? Who needs more testing? I want to talk briefly about loss of gray matter because there is changes in gray matter that we can't necessarily say hearing loss leads to loss of gray matter. However, what research does show is loss of gray matter is proportional to the degree of the audiometric hearing loss, especially in the right auditory cortex. Now, again, what we don't know is, did one lead to the other? Is there something underlying that's causing both? That's what we don't know. We also know that the prefrontal cortex has a decline of volume and thickness, which contributes to the declining ability to hearing and noise. So we need to just stop focusing on hearing aids. These hearing aids are amazing in noise. They can be, but what is happening to our patients centrally? What is even possible for them? And then we have to look beyond the hearing aids and be looking at what other options there are to help our patients function in everyday life, which is what they're coming to see us for. Aging and hearing loss may result in atrophy of cortical auditory regions and most listening becomes more effortful, reducing available cognitive resources. So what happens when I go into a noisy place and I have normal hearing? I have to work really hard. I have to pay attention. I have to focus. I have to use executive function, memory. And I'm using, if you listen to Dr. Sharma, I'm using those higher level cognitive processing. This is lighting up while I'm listening. For our patients who have hearing loss, this is every day, all day for many of our patients. And that leads to stress and fatigue and exhaustion, and it's reducing available cognitive resources to do other things like remember, walk, things like that. Again, Dr. Sharma's work, she and her colleagues found that greater cross-modal recruitment of the right auditory cortex was seen for patients with a greater degree of hearing loss. They also had poor speech and noise scores and poor cognitive function. So it's all kind of going together. Changes in central processing lead to less success with hearing aids. That's a problem. The study was done by Dr. Harvey Dillon and his colleagues in the UK, and they found that only half are wearing their hearing aids most of the time. This is in the UK, where hearing aids are subsidized, yet they're only helping 42 or 45% of people, even though they're subsidized, and they're only half are wearing them all the time. 30% sometimes use them, and 20% are in a drawer. And I think that's true here too. And I think that this might be because we're not looking at the entire auditory system and we're missing some key information for patients, because traditional audiometry just doesn't give us enough information about the consequences of some of these age-induced and really just peripheral changes lead to these changes in the central system as well. So I'd be careful to say, oh, this is a problem for our 80 and up or 75. We need to start looking at this. This was the recommendation of the study, which I don't think I referenced here. No, it's Gates. We've got to be careful because we need to be hitting people before they get to this point, just like in looking at physicians diagnosing dementia sooner and mild cognitive impairment sooner. We can't wait until it's there. We're trying to be more proactive here, and we need to be testing and intervening much earlier than this. And I've seen people with central problems, younger than myself. I'm so young. In their 40s even. So we can't just say this is an aging thing. That's ageism. That's not true. It's just more prevalent. Central auditory dysfunction is a precursor to Alzheimer's dementia. The Gates and colleagues recommended that we're doing some kind of central screener. This change in approach is really important because it really changes outcomes. Involvement of the central nervous system in cognitive decline compromises success with amplification, as I just said. Also, defining auditory processing and cognitive issues can help direct management and might help direct better selection of amplification assisted technology and counseling. And absolutely 100% that's true for me. I use this information to decide what hearing aids are best, for sure how to fit them best. Is this enough? Does this patient need a remote microphone? Does this patient need more help from family? Does this patient need auditory training? What other rehabilitative strategies can we utilize to achieve the goals that this patient is looking for? There's less reliance on hearing aids. Hearing aids are not a magic wand. And I've been practicing long enough to be tired of people. I think they're amazing. Don't get me wrong. I love hearing aids and I love cochlear implants. But we need to be looking at more strategies than that for patients who have central problems. Improves the perceived value of treating hearing loss. So even with a patient, so what was really surprising to me when I changed this approach, I started doing these functional hearing assessments, are the patients who had great cognition, no central problems, and they had a mild to moderate hearing loss. Okay, you think over the counter. Those are patients who walked in saying, I don't want hearing aids. I don't need them. I can manage without, which by the way, is the #1 barrier to moving forward. I can manage without is the #1 thing in studies. that are listed as reasons that people didn't move forward. What these patients don't understand is what that means. And that it means that instead of working here, they're working here, they're working harder, and that's taking up some cognitive reserves. And do they really want to do that? And the answer for these patients is no. But I can't just say those things. I really need to test, and I can say, hey, look, you're doing okay, and you can manage without because your cognition is good. It looks like things from here to here are working okay. You really just have an audibility problem. That's very treatable, very, very treatable. And it's silly to not treat it. And so my adoption rate of hearing aids and cochlear implants is over 90% when I do a functional hearing assessment. So patients just have a much better understanding of what's going on because we collected the data. We talked about real world experiences. It's a much more effective expectation management. There's only so much you can do when there's some cognitive changes. This is 100% patient and family-centered care. And the focus is on rehabilitation and not just on hearing aids. And that's really what we need in hearing healthcare. I just want to thank you so much for your time. Feel free to reach out to me via email. And if you want to check out that training program, you can do so at cognihear.com. Thanks so much.
Welcome to our course. I'm so excited. I'm Dr. Natalie Phillips of the Audiology Center of Northern Colorado here in Fort Collins, Colorado. And besides practicing and doing hearing and balance diagnostics, we do amplification, cochlear implants, as well as I specialize in management and evaluation and management of tinnitus and sound sensitivity issues. So with that, I got introduced to the wonderful Dr. Danny Mystery of the Asher Brain Clinic. He is an internal medicine doctor specializing in sports medicine, and he also practices in sports cardiology, non-surgical orthopedics, and integrative concussion management. So we're going to present to you today on some of the things that we have learned together. We are an interdisciplinary team that has come together. In addition to, you'll find out some of the other specialties that provide care for brain concussion, or I should say concussion management. And so with that, I'm not going to read the learning outcomes. You guys can read that on your own, but we're going to kick off this course and learn a little bit more about integrative management of traumatic brain injuries. So with that, I'm going to pass it over to Dr. Danny Mystery.
Thank you, Natalie. So the background that I've chosen for this Zoom meeting is ironic because the mountain behind you is called the Killer, the Savage Mountain, K2. And it's arguably the hardest mountain to climb next to Annapurna. Actually, Everest is one of the easier mountains to climb. And concussion management is a very difficult mountain to climb for patients. So I just wanted to put that mountain in the background to kind of symbolize what our patients go through and how Natalie's role is so critical in healing these folks. So start you off with a simple slide that talks about the simple truth about brain rehabilitation, which needs comprehensive evaluation. We'll talk a little bit more about that. Early intervention is key, and sometimes we're not privy to that because people come sometimes weeks, months, or sometimes years after they're concussed. And then meaning rehabilitation. If we achieve all three facets, then people do get better, no matter how bad the concussion was. Obviously with some residual symptoms, which can last a lifetime, but obviously our hope is to heal everybody 100%, but sometimes that does not happen, as is the case in any branch of medicine. So the team approach that we've found to be helpful, surrounding about 700 concussions, which we've seen in the past 3 years since we opened this integrative clinic, is it begins with the individuals, the parents and families, teachers, coaches, and support staff, if the concussed person is in high school, college, or beyond college, and they're still students. And then the healthcare providers, ironically, are the last facet because concussion, as we know, is a family injury, and the care begins at home. So our goal is to kind of empower them with tools that they can understand what concussion is, how we integrate our approach, and how we can make them better. So the vision that we have is the CARE model, C-A-R-E. C is we all have to have a commitment to excellence. We all have to communicate, which is not hard in this day and age of the internet. We have to have some form of consistency of care. The patients have got to have access to care. It needs to be affordable for them. They need to be aware of what is going on because knowledge is power, as the great Thomas Jefferson said, and I'm kind of a little biased to Thomas Jefferson because I was at the University of Virginia as a team doctor in Charlottesville. And awareness is very, very key. And we strive to educate our patients about the knowledge of concussion, the knowledge of concussion management, and what recovery looks like. We have to respect the fact that every brain is different. It's a mass of 100 billion neurons with about 150 trillion circuits. So to expect everybody to recover in the same fashion is an unrealistic expectation, which we've learned. Resolve to keep giving your patients positivity, and then addressing evolution, adapting to change regarding the principles of medical management, especially concussion management at the time, not waking up people in the middle of the night, letting them get their good sleep so the brain can recover, etc. Educating our patients, and then to the best of our ability, providing expeditious care. So we know from experience, and we didn't know this 30 years ago, that brain injury is truly a complex problem. It's a processing dysfunction at many levels in different lobes of the brain. And as we know through these 150 trillion circuits, that the brain is just a buzz of electrical activity happening all the time. You know, talk about a video game and sitting inside the brain. I'd love to just sit inside the brain and feel all these circuits just reverberate around me, because all the different parts of the brain are talking to each other. So when you have that, you kind of almost need to separate the symptoms to understand where the complexity lies. And that makes a huge difference. So we like to separate into 4 domains what the patient might be experiencing. While they're all connected, we just like to separate into the domains and track the symptom progression with rehab over time to see which domain is getting better. For example, on the physical domain, if they have tinnitus, or they have hearing loss, which we know is associated with an early risk for dementia. We know that repeated concussions are associated with repeated risk for dementia. So tracking their ear symptoms, dizziness, vertigo, sound sensitivity over time, and grading it over time with rehab is key. So we take this model of these different domains, present it to the patient, have them fill out a form, and track their processing dysfunction with the goal of orchestrating their function back to normal. The team that takes care of the team to help resolve these symptoms include healthcare providers, including nurse practitioners, PAs, MDs, DOs, neurologists, neuropsychologists, etc. Audiology, ENT, and optometry ophthalmology is very key. So just think about this for a minute. If you eat bad food, your gut doesn't feel good. You have vomiting and diarrhea. If you present the brain with bad information from the ears or the eyes through the vestibulo-ocular reflex, which tends to be affected negatively by the concussion, then the brain is not getting good food in. And junk into the brain means junk out, which means cognitive dysfunction, which means frustration, which means stress, anxiety, which means dysfunctional human being at home and in the workplace, irritability, and then it just spirals from there. So getting early evaluation by audiology, otolaryngology, optometry, and as needed neuro-ophthalmology by people who are passionate about understanding the concussed ear, like Dr. Phillips and other members of our team, is very, very critical on the front end. If we don't do that on the front end, we're not doing the patient a good disservice. The other facet is very important, is to have good neurocognitive testing early in the game. So you're checking what their scores for verbal memory, visual memory, reaction time, and processing speed is, because all those parameters have been shown to improve with good vestibular eval and therapy and good ocular eval and therapy. Neuropsychology, like any other science in medicine, has its role in concussion management, but it costs a lot of money on the front end. And it's very hard for people who are acutely concussed to sit and test for 8 to 10 hours. So a quick neurocognitive test, which we'll talk a little bit more about in this presentation, is a good starting point as we do that comprehensive evaluation. If you remember the slide, comprehensive evaluation, early intervention, meaning rehab. And the integrative therapy is the meaning rehabilitation. And then if patients have lingering symptoms, we have great neurologists we work with for medication management, for headaches, with Botox and triptans and trigger point injections, and even membrane stabilizers. But one of the problems of treating people with concussions with medications much too soon is some of the membrane stabilizers have side effects that mimic concussion. So there is a restrictive nature to that. But long live our neurologists who help us move forward. What we have found, just to repeat myself from the previous slide, is that early audiology, ENT, optometry eval in about 90% of our patients, I think Natalie and I have shared hundreds of patients, gives us an idea what is going on. Do they have hearing loss that needs to be corrected? Because we do know from experience, if you look at a picture of the inner ear, this remarkable organ, which is so tiny and still, in my mind, controls the brain. Because if you've got vestibular dysfunction and you don't fix it, the brain's not going to get better. And we'll talk a little bit more about that. That fine balance in that inner ear is critical for fine balance of the brain, fine balance of life. And whoever put that picture of the rock with all those rocks stacked on each other, I'm not quite sure if there's super glue in between them, but I'm told that it's not. I have a hard time believing that, but that's how delicate the balance in the inner ear is, and paying attention to that inner ear balance, where, as you all know, balance is intimately linked to hearing, and through the 8th cranial nerve provides vital information to the brain, controls the eyes with vestibulo-ocular reflex, and then we have some slides to show you on how that is critical to higher level functioning of attention, memory, etc. So in descending order, 75 to 45% of individuals with concussed inner ears complain and present with headache. So they immediately go get a CAT scan, MRI, and it's not the case. So many cases do not get imaging. They get good vestibular rehab and the headache gets better. They feel slowed down because the brain's not getting good food. The energy is down in the brain. They have difficulty concentrating because the brain stem is not communicating with the higher centers through the hippocampus. Dizziness and fogginess is an early feature. In fact, it's been shown that people who present with dizziness as an early sign in the early post-concussive phase have prolonged recovery. So vestibular rehab is very, very critical. Fatigue is omnipresent in about 80% of people with concussion, even a year to 3 years later. And those who have early vestibular rehab, the fatigue gets better, because we know fatigue is not just cognitive fatigue, because if you're cognitively fatigued, you don't want to exercise, and vice versa, right? So it kind of goes hand in hand. Visual blurring and double vision could be purely vestibular. I can tell you I've seen numerous patients sent to the best neuro-optometrist. They have nothing wrong with their eyes, and they still have visual blurring and double vision being driven by the vestibular system. Light sensitivity is common. Memory difficulty, less spoken of, but very common, and balance problems, which get better with vestibular therapy. If you think about concussions and vestibular dysfunction, and you think about the vestibular system and how it communicates with the cerebellum and then with the higher centers through the vestibulo-ocular reflex to maintain balance by motor integration, it lends credence to what we just talked about, the 150 trillion circuits. We cannot go into the brain and separate and say, all right, which circuit is affected, right? I wish somewhere in the future, in like 200 years down the road, we'll get a new Captain Spock and we'll be able to figure that out for us. But enough said that why the sense of balance is fundamental to concussion recovery is detailed in this slide, where the sensory input is so key to understanding integration of input, viz memory, viz ocular function, and why when balance is affected, you can easily point the arrows in the reverse direction, that this conglomerate of circuits is controlling concussion recovery. It's a beautiful thing, right? Because we also know when you have vestibular dysfunction, you can have affective disorders, and your cognitive impairment is real. We've seen this so often. We're just starting to crunch the numbers on 650 to 700 concussions. And one of the things we want to show is that people who have had early vestibular therapy, anecdotally, I know that's true, but it'd be good to look in the data form. And hopefully in a year, we'll be able to show that those who had early vestibular eval, early hearing evaluation by Natalie, actually did better cognitively sooner than people who did not. And I'm convinced that we're going to show that, because we've been tracking it without data analysis, but we just started on the data analysis actually last week. So the take-home point here is concussions cause vestibular dysfunction affects memory. And as we know, bad memory, not good for the soul, right? So untreated vestibular dysfunction can cause prolonged changes in cognitive function, is very key to know, which then becomes an epidemic and affects the workplace, affects home life, affects being a parent. For the child, it affects being a good child. And then conversely, we've shown that when you do vestibular rehab, actually people get better. There are several studies that I've listed here, and rather than just repeat the studies, I'll let you read what the studies have shown. And I can tell you the studies by Gurvich, review article. It's not really a study, but it's got good studies within the review article. And then the review article by Gudetti. And actually that was a study by Gudetti, and the review article by Smith, I stand corrected, showed that people with bilateral vestibular damage actually have atrophy of the hippocampus, which correlates with their degree of impairment on spatial memory tasks. And we also know it's not just visuospatial memory, it is higher level cognitive function as well, such as attention reaction time. So it's just important to know that the vestibular system is not just important for visuospatial memory, but also for higher center function.
All right, so in walks audiology. So Dr. Mistry sends us a lot of patients, and what we usually start off with, and this is just kind of talking in the audiology world now in ENT, but what we usually start off with is a regular hearing test just to rule out any peripheral hearing, as well as any retrocochlear pathology if we need to go a little bit further. We do also do auditory processing evaluations to see, because honestly, people that are coming through from Dr. Mistry that have brain injuries, they might not have a peripheral hearing loss. And so we do the central testing and we do the auditory processing to try to figure out what subcategory that they have so that we know how they can get rehabilitated. Sometimes we then do talking about the balance, right? And talking about just the disequilibrium or the vertigo or whatever it is with the brain injury patients. We do VNG, VEMP, sometimes ECOGs as well. And then a lot of patients are coming through with tinnitus and sound sensitivity. I know that Dr. Mistry had talked about photosensitivity, right? Light sensitivity. But when you have that type of sensitivity, sometimes this also bleeds into sound sensitivity and also tinnitus, depending on what happened in that brain injury. And so we do sometimes then move these patients into more of the consult evaluation and management and treatment of tinnitus and sound sensitivity. And then the ear, nose, and throat, the ENT side of it, they will determine whether or not any other imaging or other tests or therapies are needed in that world. So I'm going to pause a little bit and kind of go through what I do with tinnitus / sound sensitivity patients. And typically what we start off with is we start off with a consult. So after we do the basic peripheral hearing test and the central test or the APD evaluation, they might come back and see us for tinnitus or sound sensitivity. So I set up a consult, which is about 60 minutes. And the reason why I don't just go right into a tinnitus evaluation is because there is a consult code that can be used. And we ask that the patients pay up front. And if they were to actually go forward with management of their tinnitus and sound sensitivity, that consult fee, you get paid for your time, but depending on if you want to do this with your clinics, you can then take it and put it towards the purchase of any devices that you're going to use for the tinnitus and sound sensitivity management. But really, this 60 minutes allows me to spend time with the patient, learn more about what's going on with their tinnitus and sound sensitivity. And I'm going to go over some forms and some questions. And it narrows down who just needs amplification to work with their tinnitus and who is actually what I call a true tinnitus patient that actually needs my services and my guidance to help them actually get over or reduce their tinnitus awareness and disturbance. And so I start with the consult first. And from that consult, this could turn into a hearing aid consult, or it can turn into the tinnitus evaluation or the sound sensitivity evaluation that I then schedule out anywhere between 60 to 90 minutes, depending on how these people are taking in this information. And so with this evaluation process, I usually invite a spouse, a family member to come back so that they can have an extra set of ears to go through what I'm going through with them. And you'll kind of learn what I go through with them. And we do the tinnitus testing there, the loudness balance test. We do, these are the different codes that you can use. Again, getting paid for your time that you're spending with them. And then you can also order devices at this appointment if that's the next step. So in the tinnitus consult, I do actually have people fill out some questionnaires. It's the Tinnitus Reaction Questionnaire, the Tinnitus Handicap Inventory, and the Tinnitus Functional Index, as well as a depression and anxiety scale. And so fortunately, but unfortunately, they complain because every time they walk in my door, I have them do these questionnaires because I like to make sure I see any changes that's going on with them. And so they started with those questionnaires, and then I go over patient case history. And I know you can't see, this type very big. However, I do have some of the questions on another slide here, but I do spend time. What I want you to look at on this case history form that I have is that I do spend time looking at their tinnitus, looking at their sound sensitivity, whether they have hyperacusis or misophonia. And then I have a little section on the bottom that also covers their hearing. And so those are some of the things that I want to make sure that I look at. I don't just look at tinnitus, but I also make sure that I incorporate that hearing and then any sound sensitivity. And between those three things, sometimes I have to ask them to rank it out in order for me to figure out what we're going to do or strategize what their therapy is going to be like. And so maybe if they rank, sound sensitivity as first or tinnitus second and hearing last, or whatever it is, it's important to rank them in order so that you know what's the most important to them. So in that case history, with the questions that I go over, these are some basic questions regarding just their tinnitus. So again, sometimes when you're interviewing them, they answer, if they're ranking sound sensitivity first, when I'm asking them about their tinnitus, they tend to tell me about their sound sensitivity. So I really go through, and because I've got 3 sections on that form, I really go through and make sure, no, we're talking about your tinnitus. Let's just focus on tinnitus. And whether that's third on their ranking, I still make them focus on their tinnitus to answer those questions. So some of these basic questions are, obviously, if it's 1 ear versus 2 or somewhere in their head, if it's intermittent or constant, if it fluctuates in volume, if they have bad days versus good days, you get your basic history of when did it start, how do you describe it, what's the percentage of awareness and disturbance. I also want to know if it affects their sleep patterns and if there's any other medical things that I need to take a look at as well. Then I've got some other additional questions regarding the tinnitus, if it affects their concentration or quiet recreational activities or when they're still at work. When you leave a loud area, is it worse? That's looking for reactive tinnitus. I also look for support systems. So who do you live with? What do you do for work? Are there any increased stress levels? I'm looking for, are they able to control their stress levels, right? And then any other things that can make it exacerbate, such as colds, medications, loud sounds, ear protection. I also want to know if they've tried anything recently, so that I can talk to them about what may have worked or what may not have worked. And then also, I love that last question of why is tinnitus a problem for you? And this is really going to the emotional part of tinnitus, and it really allows them to tell me why is it bothersome for them. And so I take note of that. Now, when we shift to the sound sensitivity questions, it's a little bit different. Obviously, I'm looking for, is it just oversensitive to sounds? And when I ask this question, I ask it, are you sensitive to moderate everyday sounds, not loud or sudden sounds? So that's that oversensitivity. And so I want to make sure that it's anything that anybody else would say, oh yeah, there's a regular sound in this environment, and it's not just that's what they think is loud or sudden sounds, because any one of us could go into Home Depot and somebody drop a piece of lumber and we would jump, right? Those aren't the ones that I'm looking for. I'm looking for everyday sounds, moderate level sounds, whether or not there's physical discomfort. And then we talk a little bit more about when did it start? What are the types of sounds? Now that's really interesting, because when you're talking about types of sounds and you're having them tell you, even though they're not able to tell you if it's a loud or sudden sound, you can start making notes of this. Like if it's a vacuum cleaner, if it is every time I blow dry my hair, I've got to put earplugs in, or I stopped going out without earplugs, and it's because when we go out to a restaurant, it's pretty loud and bothersome. And I ask them questions besides that. I don't stick to the questions on my sheet, but I say, well, were you with somebody at that restaurant? Was it loud? Was there background noise? Did the person that you were with, did they have problems too, right? And so it allows them to kind of compare a little bit more, but it also allows you to learn if you're looking more at hyperacusis, right, which is this blanket of sound where if something gets over this level of sound, of this moderate everyday sound, then they've got to put earplugs in. Or if it's misophonia, if it's something that is a particular type of sound, it doesn't matter how loud it is, that gives them a physiological response. And so the best way that I can say would explain that would be like fingernails on a chalkboard. Fingernails on a chalkboard, you get this physiological response, that hair that raises on the back of your neck, right? And so you're looking for what they are telling you that they have the sound sensitivity for. And then also I ask if they use ear protection, and then if it also affects or prevents them from normal everyday activities, and if they've tried anything as well. Then I spend some time going through some directive counseling. And directive counseling, I really go over and I like patients to understand what they are learning about, what maybe they might have, so that when I explain how we're going to actually use tinnitus or sound sensitivity management and therapy, that they understand, okay, I get it. This is why I'm doing this. So I go through some of the different things that I'm looking for. I go through definitions and statistics of tinnitus, and then also the different types of sound sensitivity. I talked about hyperacusis and misophonia, as well as phonophobia is when they're actually avoiding places because they know that there's going to be a certain sound that might set them off. And so we kind of talk through some of those definitions. Then I talk about the Heller and Bergman article where, there were people that were put in a booth and they had normal hearing, and they were told that whenever you hear something, push this button. And the researchers walked outside, didn't present anything at all. And 96% of normal hearing people started to push the button. And when they walked outside, the researchers said, describe to us what you heard. And people said a ringing, a whooshing, buzzing, humming, katydids, crickets, the ocean, music, everything that we describe as tinnitus now. And they proved two things in that article is that number one, normal hearing people can have tinnitus. And number two, when you're put in a quiet environment, your brain is able to pick up on softer level sounds that could be occurring all the time, but you don't notice it because there's so much noise in the environment. So most people start to notice their tinnitus when it's quiet, when they first go to bed at night, when they first wake up in the morning, when the world is at rest. And so this Heller and Bergman article, I really like to educate people about this, letting them know that 96% of patients that have normal hearing also can have tinnitus, right? So it doesn't have anything to do possibly with the hearing loss, but it could be something else that's going on. And then we go through this neurophysiological model of sound, basically teaching them how sound works in the brain, that it starts in the ear, but goes up to the subcortical level of the brain where there is detection. Then there is, if it doesn't have any meaning to you, it can go out the door there. But then there is that higher level of cortical level where the sound can go up there. And then it's not just detecting it and letting it go out, but you perceive it and evaluate it at the cortical level of your brain. Then it can get to your limbic system where there's that emotional association, making it linger because you have this emotional association of, what am I going to do? It got louder. I've got to go see somebody now. Is it going to get better? Is it going to get worse? Did I eat something different? Did I do something different? Right? So there's emotional associations in this limbic system that keep tinnitus or this perception of sound for people that have sound sensitivity there and longer. Sometimes it can then get to the autonomic nervous system where you now have physiological responses coming out. And then it goes around in this cycle and it's hard to break. And so we go through that neurophysiological model of sounds. That way people understand what is going on. And then we go over management and treatment available. We go over, pricing range for different devices and therapy, and then further agreements for follow-up visits. So again, tinnitus evaluation. In that tinnitus evaluation, again, they get those questionnaires, but I also do some other testing as well. We look at ultra high frequencies up to 12,000 because we want to see what the hearing loss drop is, as well as otoacoustic emissions, loudness discomfort levels. That's going to tell us if it's hyperacusis or misophonia. And then I go through tinnitus parameter testing, which is the tinnitus loudness match. So first of all, I look for what consistency is it, and I can only do it to the level or limits of my audiometers. So sometimes it's either a whooshing noise or a tone or a pure tone or a warble tone, or even kind of a broadband weighted noise. And so I look for the consistency of what their tinnitus sounds like. And then we go through the pitch and the loudness match, which is that TLM. Then the broadband noise minimum masking level and the narrowband noise minimum masking level is what I test next. And what's interesting about this is they tell me two things in this test. They first tell me where is this first masking level that they hear it, so their threshold. And then as I raise it up, then they tell me how much do I have to turn up a masking level sound in order to cover their tinnitus. And there's that distance, right, of their threshold for when they first hear it and when that masking level covers it. I'm not looking for a minimum masking level so that I know how to set their devices to cover their tinnitus, because if you mask or cover their tinnitus, their brains will never learn to ignore something if they can never detect it. However, what I am using this this dynamic range, I should say, is because through tinnitus management, I do these different tests again. And what I'm looking for is not necessarily that the tinnitus loudness management or the tinnitus loudness match is going down. So let's say they identify their tinnitus at 18 decibels. Yes, I'm looking for it to drop down to maybe, anywhere between 2 to 5 or anything like that. But I'm looking for the minimum masking level to drop. So let's say, for example, their tinnitus loudness match is at 18 decibels, and it takes a broadband noise of 36 decibels to mask their tinnitus, and a narrowband noise of 52. Okay. And I'm throwing out these numbers, so I hope I remember what numbers I'm using. But basically what I'm saying is when I test them throughout their management, I'm expecting that minimum masking level to go from 36 and 52 to maybe, 20 and 40 and lower, and it's really taking down that dynamic range, because what that's telling me is that their perception of tinnitus, the masking level that I have to give them is coming down, which means their perception of tinnitus is actually coming down, right? They can still loudness match it to 18 decibels if they want to. However, their perception, which means their brain is actually changing that perception of tinnitus, because I don't need as much masking level, right? And so that's what we're looking for. Residual inhibition is another test that I use just to see that if I were to give them some sound for an extended period of time, what happens to their tinnitus? Does it get worse? Does it stay the same, or does it get better? And it tells me whether or not sound therapy is going to be able to help them or not by doing that test. And then again, we take the time to spend going over those some questions or counseling with spouse or family members, and then we talk about any strategy or any devices needed. So again, this is the tinnitus parameter testing. And then we go through considerations. So with those considerations, again, with those 3 sections, remember, I look at tinnitus, hearing loss, and sound sensitivity. And we try to figure out if they have 1, 2, or 3, and in what order. Then we go over financial considerations with some of the different types of devices, as well as, this is important too, the motivation and lifestyle. Do they have that support system at home to help them? Do they have that motivation, or if they're thinking that, I'm going to just be using these devices when my tinnitus gets bad, things like that. So we look at a lot of those different things to see if they're going to be a good tinnitus or sound sensitivity candidate. So with tinnitus therapy, this is for tinnitus, not for sound sensitivity yet. Some of the different points to remember about sound therapy is that we want to consider everything. We want to consider hearing loss, tinnitus, and sound sensitivity. If sound sensitivity is first, I cannot treat hearing loss or tinnitus until I fix their sound sensitivity. Otherwise, they're not going to be able to use their devices how we need to. In tinnitus sound therapy, the patient should never strain to hear. The sounds that they're using from their devices should never evoke annoyance. That they should be easy to ignore. So therefore, like not using music or anything that they're going to hum along to, right? Because that's a different level of brain activity. But we want them to be able to hear something, but then have no meaning. So no patterns, no meaning at all that they're using. And then also to be able to hear their tinnitus. The sounds that they're using should not sound like their own tinnitus. They already have an aversion to their tinnitus. So you wouldn't want to treat them with a sound that sounds exactly like their tinnitus, but instead you're training them to listen to a sound that they have no association with, in order for their brain to get back on this schedule of, I hear something, but I'm not going to pay attention to it. Okay. And then for tinnitus, they set it and forget it. Now with sound sensitivity, the protocol is a little bit different. Okay. So again, depending on what you're looking at, we're looking at hyperacusis. This is just, again, what we would do for sound therapy. And you guys have the slides, so I'm not going to kind of go over all of this. But typically when I'm treating hyperacusis, it is using ear level sound generators and tabletop sound generators, typically about 3 to 6 months of therapy. I have to say I've seen the fastest recovery in about a week of hyperacusis, and we were able to then move on to either tinnitus or hearing loss, depending on what we needed to. So there's just a little bit different protocol for hyperacusis. And then misophonia is just a little bit different too. Sometimes we use music therapy, and we allow people to have some time spent to do some music therapy it's a 3-week cycle, but they get to choose the music and they get to set it. And it's something that it's pleasant for them to listen to. And misophonia is a little bit different. Sometimes we combine misophonia therapy with some other ear level sound generators as well. So again, you guys have these slides that you can take a better look at. And that's what we do. So I'm going to head it back over to Dr. Mistry to talk a little bit more about some of the other specialties here.
So, you know, with all that great stuff that Natalie just spoke about, just think about a concussed patient who has tinnitus, or misophonia, or hyperacusis. It is so traumatic. And when you treat that, I go back to one patient that we had in his early 60s. He was a patient who was injured at work. So work comp fought us tooth and nail to get the tinnitus device that Natalie had recommended. She had to write a letter to work comp, and I had to submit an appeal. And when he got that device, his life changed. And so we cannot minimize two things. One is that many people do not understand the value of audiology ENT in concussion management. Very, very critical. And two is it's our goal to educate folks in the insurance world, patients, families, etc., about the value and the intangible need for audiology in concussion management. But there's some other specialties that we refer people to in the early phase as well. One being neurooptometry. They assess vision, assess anatomical integrity. I've seen 10 patients out of the last 650 at this clinic over 3 years with papilledema, which would not have found out unless they went to a neurooptometrist who has a passion for concussion management as it relates to the eye, right? And then they assess the need for ocular therapy, advanced imaging, MRI of the orbits, which is critical to make sure there is integrity of the globe, which is very, very critical. Other things with neurooptometry that we find are skew deviation. We can find Crayling nerve fourth palsy. Convergence insufficiency is very, very common, all part of what's called the post-traumatic vision syndrome. Talk a little bit about clinical psych, school psych, and neuropsych. So the early screen that we need with a clinical psychologist or school psychologist is based on the building blocks of brain development, right? So if you think about it, if you think about your basement with having the fundamental processes of memory, processing speed, attention, inhibition, and sensory motor function, if your basement's not right and it's flooding, or there is the foundation is not good, then your intermediate processes such as language learning and visuospatial orientation is affected, which then affects the higher order processes such as social emotional competency, executive functioning, and which leads to overall functioning deficits, including achievement, cognitive ability, and reasoning. And if you think about a person who didn't know any of this before they bonked their head or their neck or the body and developed a concussion, because we know we don't need to hit your head to get a concussion, and then you take one of these fundamental processes away, right? Say you take attention away. Your basement crumbles, your higher level functions crumble, and basically you end up with dysfunction, right? So this is not rocket science. We're going to understand concussion at the roots of its management and where are we looking? So if we're looking at attention, and we know from experience that early vestibular intervention, vestibular ocular intervention is very key to higher order processes such as attention, which is actually ironically a fundamental process, it becomes increasingly clear that early referral to audiology is very, very critical for good outcomes. So what we do, we have an amazing clinical psychologist and school psychologist and staff. She either does the computerized test called the IMPACT, or she also does some paper and pencil testing with R-band. She assesses cog function, the need for cog rehab, the need for psychological counseling, because many folks get anxious and depressed when they're not getting better. And then as need be, communicating with the schools and healthcare providers, which gives you a baseline neurocognitive assessment, just like the symptoms we talked about on the slide of processing dysfunction. And we assess the brain functioning in the context that this quick screen allows us to quickly assess the benchmark of memory, processing speed, reaction time, emotional well-being, quality of life, all the functional aspects that a person needs. And then it helps us to prioritize and direct changes to treatment, helps us monitor progress in rehabilitation. And then eventually when they get better, we can give them an objective measurement to clearance or resolution. Integrative therapy could be multifaceted. And what we start is we start them with a good vestibular eval, an ocular eval by a physical therapist, adept at vestibular therapy, or an occupational therapist, adept at ocular therapy. Got to remember that loading patients with too much on the front end drives them bonkers, pun intended, because the brain is already bonkers, right? And we just want to make sure that we pace them with therapies, pace them with work, pace them with school. So speech therapy, not so much on how they're speaking. Some people have difficulty swallowing, etc., but that's the minority. The cognitive rehab part of speech therapy is critical if vestibular ocular rehab has not made them feel better. We also know that through the vestibular spinal reflex, you can induce cervicogenic dizziness, and people have tension headaches that induce cervicogenic dizziness. Treating the neck is key, especially after they've seen Natalie or an ENT doctor. We can know that it's not the peripheral vestibulopathy, maybe it's cervicogenic. So separating these two allows us to direct rehab, and then psychological counseling, and as needed, cognitive behavioral therapy and other modalities such as biofeedback and neurofeedback help. But again, pacing is very key. So integrative therapy should be paced. Makes a huge difference to recovery. Lastly, we send folks to neurology to determine the need for advanced brain imaging. We also know from experience that 90 to 95% of folks who have CAT scans and brain MRIs, all of them are normal. The studies are normal, and a concussion doesn't rise to the level of a moderate or severe TBI. So typically, you do not see changes unless you spend $10,000 doing a diffusion tensor imaging study or an MR spectroscopy or a SPECT imaging, and those are very expensive studies. It doesn't change your typical management, but sometimes patients want to know, and sometimes we have to get those. But neurology helps us guide that. They help with additional diagnostics like an EEG if there's some seizure-like activity. We can also refer to physiatry through neurology if someone has cervicogenic pathology, such as disc herniations with stenosis, causing some nerve pathology either at the central level or peripheral neuropathy, and then direct other therapies such as neurofeedback and biofeedback. Most of the time, neurologists do not want to see the folks, especially the neurologists who do not practice concussion management. They rather wait to see them as and when a need arises. Because as we know, it takes a long time to see a neurologist because they're very busy and they're very good at what they do. But patients waiting 3 months on the front end doesn't create a good psyche for them. So we treat them with the caveat and let them know that if things are not getting better, we definitely need to see neurology. And neurologists are very, very critical to our good management.
Awesome. All right. So we're going to present a case study. So this case study was actually kind of fun. This was one of the ones, I think maybe one of the first ones, but that Dr. Mystery and I worked on together. And I thought it was so interesting. So glad that a physician like Dr. Mystery had moved to Fort Collins because we got to see patients like this. So this was a 51-year-old service officer, and he had a brain injury back in 2009. And so he developed sound sensitivity issues about 9 years following, but he just wasn't getting any better. And he was from out of state. And so he was married for 28 years, lived on a quiet property. His wife was very, very incredible at just adapting to his needs. And so she would not talk on the phone around him because her talking was too loud. There was a mill across the street that was about 2 acres away, but he could still hear these high-pitched sounds from inside the home. And I know you guys are all thinking like, what? There's no way. Now, there are a lot of people with sound sensitivity issues that I think, you know, they either experience certain sounds or they have memories or they see the sounds happening. And that sometimes these sounds then end up being sounds that they are very sensitive to. He didn't have any physical discomfort. He just was really sensitive to these sounds. And so he would wear earplugs whenever he stepped outside of the house, sometimes even in the home as well. So 3 years after the accident, he was seen by an audiologist and he was diagnosed with some hearing loss and hyperacusis. And they tried some sound generators, but the sound was too distracting. And so a lot of the times with people that are concussed or have a brain injury, a lot of the times when you try to do sound therapy with them, the sound that you're delivering actually ends up being more distracting and more taxing on their brain. And so that's why you've got to be very careful and just kind of know some different options of how to work with different patients depending on what's going on in their brain. And so a lot of the times the people that you see that don't have brain injuries, they're pretty much, I don't want to say any case is cut and dry, but you can kind of follow the protocols that you know in working with tinnitus and sound sensitivity. But with the brain injury patients, it could be a lot different. And so, you know, I would encourage you that if you do start to see patients that do have brain injuries, to take your time and to try things that are out of the box to see if it's going to work, because you just never know, especially with sound therapy, what's going to work and what's going to make it worse for them. So I wanted to just kind of pause on that. Now, when he came in to the office, he was flown in. There were there was a company that was like investors, and they were all in my office because what we had partnered, what Dr. Mystery and I had partnered to do in addition to our services, is there was a group of engineers at the Colorado School of Mines, and they called themselves the Eargineers. And they were going to develop some sort of electronic plug that would, instead of me doing my normal sound therapy that I would have, knowing that he had done this in the past, we were going to try something different. And although I initially fought with them saying, no, he's not going to be fixed if, you know, we can't get some sound therapy and to retrain his brain, it was very apparent that we couldn't use sound therapy. So what they were going to do was they were going to make an electronic earplug that would allow the attenuation of certain frequencies when it got to a certain level. Okay. So my job was that I had to get him in the booth and do some testing to find his loudness discomfort level. So when he first came in, he would not come back into the office. He stood by the door. He had a little backpack on, and he literally was about ready to bolt from my room. His wife was with him. So what happened was I ended up just talking to his wife, and I lowered my voice because when I get excited, I get really loud. And so I had to lower my voice, be very intentional about the way I talked, not to get excited, even though I was so excited. He was in my office finally. And his wife went over the case history with me. We took our time. So I made sure that we had clinic time just to really roll with whatever was going to happen at that visit. And I was a little concerned because everybody was there just waiting in the waiting room for me to come out with some results. And I kept thinking, oh my goodness, I'm not sure if I'm going to be able to get results. He doesn't even want to be here. And so as we went over the case history, his wife was a great historian. You know, what I wanted to do, I explained to him, what I wanted to do was at least do a hearing test with him, try to get his loudness discomfort levels. And then I'd love to be able to explain how sound works in the brain so that he and his wife would be able to understand what it is that I'm trying to help them do, as well as the eargineers trying to develop this electronic plug. And so he literally looked at me and it was like, no way, you know, and I thought, oh boy, okay, how am I going to get him in the booth? So we were in another room. So I used my clinical skills and said, you know, my voice is pretty loud. And I'm sure that if you were to sit in my booth while I talk to you, like it won't bounce off the walls as much. And it's probably going to be quieter. So you could have a seat in the booth while I continue to talk to your wife out here. So I got him in the booth. And then I proceeded to walk in the booth, and I told his wife, I'm just going to close the door. Okay. And so I proceeded to talk to him and say, look, I said, I would really love to be able to test you, and I'm going to lower my voice. My booth has windows. And so you can see that when I close the door, it's a lot more controlled in here. And I will be able to watch you from the outside, and I will be watching you, and I will not do anything that will be upsetting or bothersome to you, because I will be able to watch you the whole time. And I said, this is what I would love to do. I said, a hearing test looks for thresholds. So these are going to be really, really, really quiet sounds. I said, I would love to do loudness discomfort levels, because there are people who want to help you and be able to make these electronic earplugs. And I said, so if I could just ease up, and I'll give you a little chart, but I'm going to be watching your eyes and watching you and watching every movement. So the minute it gets to where it's bothersome, or the second I should say that it gets to where it's bothersome, I'm going to take that as like, you don't want it any louder than that. And then I said, the rest is just me talking to you guys, you know. And I said, but I would love to be able to do that. So he was able, oh yes, and he was wearing earplugs at the time. So he was able to remove his earplugs. And that's when I explained to him how I could do the testing. And again, I told him, you know what, you're in the booth. The booth door is closed. I am not going to make any, you know, big movements. I'm going to control my voice. I'm going to talk to you, but I do need to explain how I need to test you. And so I was able to get 17 points of data from 125 Hertz to 16,000 Hertz for both ears of his loudness discomfort levels. So you can kind of see now as an audiologist, if you're looking at that, right? So let's look at that chart. So across the horizontal axis are your frequencies. So you can see 125 up to 8,000. And then on the bottom, I have my handwritten 9,000 to 16,000. So frequency from left to right. From top to bottom is your decibel levels. So from -10 all the way to 120 decibels. Now, the average person, I would say anything less than 70 decibels, okay, is considered decreased sound tolerance, or yeah, I would say hyperacusis, so decreased sound tolerance. 70 to 90 would actually be more of that decreased sound tolerance. 70 and less is hyperacusis. And then 90 decibels and higher, if they're able to get up there, it's pretty normal, everyday type of, that's about when it gets too loud for people, right? An airplane flying overhead, if you're standing right underneath the path, would probably be close to about 115 to 120 decibels. Normal conversational speech is about 50 to 60 decibels. Okay. So just to kind of give you a frame of reference for people who are not understanding that. Now, audiologists, those U's, you are seeing what you're seeing, because in a regular hearing test, you would see circles and X's, right? U's are your uncomfortable levels. So I was able to see that anywhere from 35 at 125, right? And the blue is the left ear, the red is the right ear. And in the higher frequencies, he was able to tolerate it just a little bit more, maybe up to like 65 or 70. But man, like me talking at 50 decibels, that's why he had earplugs on. And so this allowed us to see the peaks and the valleys of where it kind of goes, you know, even that U at 25 decibels on the left ear at 2000 Hertz. Yeah, he wasn't able to tolerate anything over 25 decibels. 20 and higher is normal hearing. And so that was 5 decibels over maybe normal hearing at 2000 Hertz on the left ear that he wasn't able to do it, to tolerate. And so using that data, the ear engineers were able to create some customized filtered headphones they made him. And so he was able to go home with that and be able to use that. And we got, Dr. Mystery and I received some great letters and from his wife. And I know you can't quite see that, but that was Thanksgiving, where he was actually enjoying Thanksgiving meal with his family. And on the right-hand side, it shows him that he was actually out and about heading into a store for Christmas shopping. And so his wife was so happy. But those were some of the things that we were able to do. And I love this case study because, as you can tell, you know, from him having to go through 9 years of, you know, really not getting as much help with the sound sensitivity to being able to get a little bit of his life back again with his wife. I mean, that's why we do it, right? And so I love presenting this case study. It was super meaningful for us, as well as you can see see the interdisciplinary care that took place with both Dr. Mistry and what he did, as well as even working with a group of student engineers. I thought that was pretty amazing. So yeah, so this is the case study that we wanted to present. Anything that you wanted to add to this, Dr. Mistry?
Oh, it was a fantastic case study. And this gentleman, I spoke with his wife before they came to Fort Collins, and they lived in North Carolina. And this guy was a tremendous state trooper, got hit by a driver, as Natalie alluded to, and their lives were just miserable. I mean, just think about living 9 years where you can't speak on your phone normally. I mean, that, you know, we don't think about it until it really affects us. And so that's the cool thing about integrative concussion management is this is the kind of pinnacle of what it means to have integrative care, right? This case study illustrates that plenty.
Mm-hmm. Yep.
You know, when we take care of people in our brain clinic, I have a little interactive theater for them. I have a big screen TV and I project it from my laptop. They sit next to me and they listen to the education part of the concussion management. I have a PowerPoint slide for them, talk about how we do this integrative care. We take about 15, 20 minutes doing that with every new patient. And the last slide on that presentation comes from Atul Gawande, who's now in the coronavirus task force with the Biden administration. And he talks about in his book, Better, A Surgeon's Note on Performance, he talks about the fact that better is always possible, right? It does not take genius. It takes diligence. It takes moral clarity. It takes ingenuity. And more than anything, it's really hard for these people with concussion for their willingness to try. So kind of try and encourage them with this quote and say, take this quote home. And many patients ask for a printout of this quote. And I had one patient who put it on her fridge. She was hit in a car accident. She was 62 at the time. And it took her 3 years to recover. She went back to being a realtor and a financial advisor. And she passed her realtor test on the first go. And she's functioning normally and traveling the world. And she said, I put this quote on my fridge. And I looked at it every day and said, I will be better. And so, you know, brain injury is a complex phenomenon, as we talked about, and encouraging patients to be better and giving them that positive spirit is very critical. And I kind of feel like I'm the luckiest doctor alive. I get to work with Dr. Phillips and all the good work and do all this integrative care for patients. So thank you so much.
Awesome. Well, with that, we just wanted to thank you. This is these are our websites, as well as how you can send us any questions that you might have, or maybe reach out to us. Our emails are listed below as well. So we thank you so much. Thank you to the Florida Combined Otolaryngology meeting for having us present. And we thank you so much for this opportunity.
Yeah, thank you very much.